Let's move ahead with our next panel. The next panel is going to focus on the pharmacist's role in stroke prevention and management. On this panel, we have with us Rebecca Cupp, who's the Vice President of the California Pharmacists Foundation. Anthony Morreale, who's a national leader within the VA pharmacy improvement practice. Jennifer Polzin, who's part of Southern California Permanente Medical Group, pharmacy process improvement team, and Marilyn Stebbins, who's affiliated with UCSF School of Pharmacy and founder of Mercy Medical Group. Obviously, one of the ways you can make any facet of healthcare better is by beginning to be more thoughtful about matching the clinical jobs that have to be done with the skill set of the people on your team who you assign to do it. And also, as you will hear in some of these presentations, begin to better leverage technology. So let's begin our panel discussion. And who's going to lead off? Rebecca.
Thanks. And while we bring up the first set of slides, let me just give you an overview of what the goal is of this panel, is to look at the various types of settings, give a recent example. We have a relatively limited amount of time, so we won't be able to get into great amount of detail, but just some of an example of a recent type of activity in different practice settings that a pharmacist has been involved in, and some of those results. And we're going to start with Anthony Morreale.
Thank you. They got me all hopped up on caffeine for the morning. But thank you for having me here. And I hope what I'm going to share with you in the next 6 minutes is something of interest to everybody here. And really, my position is in charge of all of clinical pharmacy for the VA. So I work at a VA central office. And I try and coordinate, and I'll say try, pharmacists from all the different facilities, 170 facilities and 300 clinics, into some cohesive system of healthcare in the VA. So I just want to mention a few things. First of all, in terms of kind of pharmacy has a long history in the federal government. Many people know Indian Health Service and the VA have been leaders in pharmacy practice for a long time. We really work on these main things that I have highlighted in yellow here. That is really improving medication safety is a key thing, improving access for patients through the use of pharmacists as mid-level providers, and improving clinical outcomes. And I think there's a wealth of data that suggests that pharmacists, if used correctly, can be very cost effective and actually save the healthcare system money. And I want to emphasize if used correctly, because I think they're high paid employees and they need to be positioned in areas where there's complex medication therapy, that they are the best people to be able to manage that. So we're going to talk a little bit about that. So this is kind of a diagram about where we had envisioned clinical pharmacists really playing the most valuable role. And that is really the bridge between primary care and specialty care. If you have very common, easy to treat diseases, somebody's being titrated from simvastatin 20 to simvastatin 40, you don't need to refer that person to a clinical pharmacist. But if they're on complex drug regimens and you can't get the patient to goal, instead of sending them to a specialty care clinic, whether it be cardiology, endocrinology, or those things, we really feel that the clinical pharmacist can play a very strong role in that particular area. In the VA, we have around a little over almost 3,000 pharmacists that have an extended scope of practice. That is, they have prescriptive privileges, they write for meds, they monitor, they have all kinds of specific mid-level practices. And this is really just to show you what areas that they practice in. And you can see that it's a very broad array of things, from specialty clinics, where they're involved with all kinds of specialty care like nephrology and oncology and those types of things, to a lot of primary care activities. So the ones in yellow here are really primary care. And you'll notice the first one and the most common is something we call a global scope of practice. And this occurs primarily in our medical home teams. These are pharmacists who have a scope of practice to manage all medication-related chronic diseases. So diabetes, hypertension, hyperlipidemia, smoking cessation, many of the things all the other speakers talked about today, those pharmacists have scopes of practice to manage those various disease states. So these are some of our trends, and you can see that since 2011, when we started tracking it, we've had a significant increase in the number of pharmacists with prescriptive privileges, or a scope of practice as we call it. You can see their encounters per FTE have gone up significantly. That means they're getting referred more patients by their primary care team. And there's been some significant numbers, so we're up about almost 4 million visits to clinical pharmacists at this time. So with that came a distinct opportunity. I'm a health research pharmacoeconomics background, and I really wanted to get evidence. And so one of the things that was always really disturbing to me is we had evidence of individual sites doing individual great practices, but we're a VA nationwide network, and what I wanted to be able to do is show that pharmacists all over the country in primary care and in specialty care clinics can achieve similar outcomes at every site that they're assigned to. So we created a project called the PharmD Project, which was Pharmacists Achieve Results Using Medications documentation project. And essentially, if you look down the box here on the left, what we designed was a tool that at the end of every time a patient saw a pharmacist, they would be able to use a little drop-down box and collect the data of what type of interventions they made. And that could be an intervention just as a pharmacist counseling a patient and catches a drug-drug interaction or catches an allergy. We wanted to be able to document that. But more importantly, when they were sent patients to do disease management, we wanted to figure out what they were being referred patients for, how many times did they have to touch that patient, what kind of outcomes did they achieve, and over what time period. So there's a whole bunch of data that we tried to do within this nationwide project. So we started in FY12. You can see the number of pharmacist tool users has risen from 117 up to 893, so we're almost at 1,000 pharmacists using this. And if you can imagine 1,000 pharmacists in the system every day seeing 20, 30, 40 patients, sometimes making 2, 3, 4 interventions per patient, every time they click that box, I get the data. So you think for all those people who are data jealous, it's unbelievable. So just in the past year, we have 180,000 interventions that we've been able to track, and then that's in disease state interventions. And then in additional pharmacotherapy interventions are 129,000. And so those are things that they weren't referred the patient for, like they were referred for diabetes, but found out that they had a gout problem, so they made an intervention in that particular area. So you can see that on the average number of interventions per visit is a little under 2 and has stayed that way for the past year. So what we're trying to do at this point is really now tie in interventions with outcomes with cost avoidance, and to try and figure out where the value is, the best value of the use of the clinical pharmacist. So they're documenting the interventions on an individual pharmacist level. We're extracting that data at a national level, and I think you'll hear later this morning about this afternoon about Archimedes. We've been fortunate to get access to the Archimedes system, the modeling system, so now we're plugging the numbers into Archimedes with our own demographics, so we know the demographics of every single patient that we see that are referred to a pharmacist. Okay, so we have patient-specific demographics, and then I want to talk to you just briefly about what we're doing with that data. So these are some preliminary outcomes, and I'll say preliminary because what we have 180,000, almost 300,000 interventions if you count both the groups, but we don't have a long enough time period to really see anything on a lot of these people. But people who started early in the process and have at least 6 months where they've seen a pharmacist. So we measured their baseline hemoglobin A1C, their baseline systolic, diastolics, and mean arterial, as well as baseline lipids. And if they've seen a pharmacist for a period of 6 months, then we measure it again at the end of that time period. And you can see what the outcomes are in the first 6 months. And generally speaking, these are complex patients that the primary care provider was having problems with that referred to the pharmacist. So they're pretty strong results, as you can imagine, going from 9 to 8 in hemoglobin A1C. And the hypertension, which is particularly relevant for this meeting, is fairly dramatic results in getting patients to achieve goal. So what we have tried to do is then plug that into Archimedes and say, what do we predict in terms of changes in clinical outcomes? And Archimedes will spend some time later today more about what their software does, but I could just show you this is a typical graph that comes out of the hypertension data that shows your reduction in MIs. So, and you can see there's, divergence of the curves happen quickly, which we expect in MI, but if you get people their blood pressure controlled, you could really start to measure differences in their potential outcomes, and that is their MIs. More important for me, and exciting for me, was the number needed to treat. And so everybody, hopefully if you're aware about number needed to treat, right, you get a certain number of patients under control. That doesn't mean you've prevented an event in every one of them, right? So in terms of hypertension, and we'll just look today because of time, in the yellow, the MI and stroke and death related to hypertension. So when we plug into Archimedes our patient population demographics, their age, their comorbidities, their other disease states, other drugs that they're on, and then also where they were at a higher systolic down to a lower systolic, you can see that for every 43 patients we get to goal, we prevent 1 MI. So then just back extrapolating easy enough as you figure out how many visits did it take to get that patient to goal at an employee cost of X amount of dollars for the pharmacist. And then how much does an event cost you? So if you look at an event like an MI, typically you have an acute event, an acute hospitalization, and then you have rehab, right? That, for a certain percentage of the patients. So your first couple year costs are listed there, and that was kind of our average best guess costs at this point in time. All of these are very preliminary. We're just starting to work with this tool. But really looking at what is our cost-benefit ratio for that. And you can see right now, I had to put death was priceless because it's, some people would argue that, that's the cheapest way to take care of patients. But clearly there's a positive cost-benefit ratio, but there's a difference between the cost-benefit ratio of MI versus stroke and hypertension versus lipids and diabetes. So, is the best use of the pharmacist to treat all hypertension or diabetes or other things? But what I do want to also tell you is that this is an aggregate. You can aggregate these, right? So if you get somebody's blood pressure down, you affect not only MI, but you affect stroke. So although I gave you an individual cost-benefit ratio, you start adding those together and you get even more robust numbers. So what we're hoping for is in the next 6 to 12 months, we're going to have probably, instead of 300 or 900 patients in each group, we're going to probably have somewhere around 5,000 to 10,000 in each group, and we're going to really refine the models of our cost and our cost-benefit analysis. So we have many future implications. I'll list them here, but for the sake of time, I would just say that this allows us to really look at what kind of patients are being sent to the pharmacist, where do we get the best bang for the buck, who's getting better outcomes, because maybe some pharmacists are getting better outcomes than others, and we can look at maybe they're using different algorithms, maybe they're using different drug therapies, so we can really start to look at what is strong practices so that we can spread those practices around the country. And we could also identify sites who may not be using the pharmacist to their highest utility. And we also have something where pharmacists, for example, get a patient to go and they keep them in their panel. And we don't want them to do that. We want them to kick them out of the panel so they can take a new patient. So we're able to, through these tools, to be able to identify things like that. So I hope that this has been at least a little bit enlightening in terms of where we're going on measuring clinical pharmacist outcomes, and I'll turn it back over to Rebecca.
Very well done, a lot of information in a short period of time. So again, the purpose of the panel is to look at different types of models where a pharmacist has been included on the team. And at this point, I'd like Jennifer to come and share a Kaiser experience. Thank you.
Hello, good afternoon. Today I wanted to bring back an old topic, but still kind of a changing topic, is anticoagulation. As Anthony said, at the VA system, Kaiser also has a very similar system in which we have 7 regions and we have pharmacists and mixed models throughout the region. But one of the areas in which we consistently have a pharmacist in each of the regions is anticoag. And anticoag has been changing over the last few years because of all the new agents. So I wanted to kind of take you on a journey, a quick journey, of what Kaiser's doing for its quality and safety with the new agents that are coming, and currently the old agent, warfarin, in our clinics. So even though Kaiser is an integrated system, we do have our challenges still because we are so big. When we started to take on this journey a few years ago, we looked at how anticoag was being done across the system after the electronic medical record happened in 2006. And what we found was that most areas had very different protocols. Some of them went away from using Epic but used a decision tool instead called DevAC. Some of the models went to 24-hour care. Some of the models had physician leads at national levels, state levels, or regional levels. And so we in formularies, different co-payments, very different throughout the regions. So we knew we had a big challenge ahead of us to kind of standardize that care. So today I'm going to talk to you a little bit about where our regions are for Kaiser Permanente and how many anticoag patients we have across the region. But since I practice out of Southern California, I'm going to focus currently on the information in Southern California. So we do service as a whole over 100,000 patients on Coumadin, but out of that, 38,000 is from Southern California. Southern California does practice Monday through Friday telecare, and our panel sizes average about 650 per pharmacist and 1,200 per technician. And when the new agents started to hit the market in 2010, we did not, at that time, use time to treat in therapeutic range. We didn't have any quality metrics besides a few metrics on staffing, TE, and bleed events, but we really weren't doing a great job, we felt, in anticoag. And with the new trials, Relay, Rocket, and Aristotle, we wanted to compare ourselves because we had a big decision of whether or not we were going to use our anticoag clinics as they stand today or move over to these new oral agents. And since we had nothing to compare it to see if we were doing better than the marketplace for TTRs, as you see in the trials, 64, 55, and 62, we knew that we had to do better. So in 2011, we started to track our data. And I want to go over a little bit about the pharmacist's role, how it looks today than what it looked like back in 2010. So currently we have pharmacists involved in improving our TTR rate. And the role is basically to standardize how we do our INR ranges, how we do our taper zones, using decision support tools in each of our areas, and how we return our stable and unstable patients to our clinics. One of the other roles that we added to our anticoag pharmacist is to actually monitor the targeted specific oral anticoagulations. So now they not only monitor warfarin, but they also monitor those agents in areas of medication adherence, risk factor dose adjustment, drug interactions, annual serum creatinine lab ordering, and also we get an OR report. Now what's interesting in EMR, what we've been able to do is basically look at areas of opportunities and build what we call clarity reports. Our favorite term at Kaiser Permanente is that we build these targeted reports to be able to give us weekly updates, monthly updates, or quarterly to ensure both safety and quality of our patients. So it's really, I think, made us improve a kind of quick time reaction to something that may have went bad. So we know our systems aren't perfect, And so these reports allow us to see patients are falling through the cracks. For instance, any patient that got a new warfarin prescription or one of these new oral drug agents and they didn't get referred to coag clinic, that's a potential patient falling through the crack. We have drug-drug interactions that we update monthly for new drugs coming to the market so that we make sure that any of the drugs get adjusted during that short window of time, especially if it's for acute med. We look at hospital admissions to see if we could have prevented that hospital admission. We also have tablet size in case something changes and we weren't from a SNF or an outside organization, so we can actually make sure that that was appropriate. And we also analyze all of our outside and inside QA reports on a monthly basis. So we think due to all these changes in the last few years, we've been able to improve our TTR rates, which we've been tracking, like I said, since 2011. So you can see here, and we mainly look at AFib for the rolling 6 months, but our first two categories are actually the whole population. So Southern California is at 69%, and our best performing area is Northwest at 74%, but when you adjust it for age, ethnicity, comorbidities, we do get a little bit closer in Southern California where we only have a 3% difference between us and the highest performing area. And if you look at AFib, we do slightly better. We haven't done a risk adjustment with that population, but we're currently at 71% and 4% from the best performing area. And our goal is to get to 77% for the patients that are going to continue on warfarin. So you can see here, this is a trend report that we do. It started in 2011, and you can see the green line, that's Southern California. So we are making progress in our TTR from just a few things that we talked about earlier, of standardization so that we can improve the TTR rate in our patients. The next step that Kaiser has is to actually bring together all of the TE events and see if the TTR is actually improving the TE and bleed rates. But what we do have today is this information, which is looking at the new agents and the old agents from 2012. And you can see here that we have pretty much no statistical differences between the two agents. And so that's a good thing. The literature, you know, there's a lot of controversy right now over the new agents, but at least Kaiser feels safe in the sense that if we wanted to move to a new agent, we are getting more, I guess, information to make sure that we're going to, if we do move to the new agents, we'll do it safely and we're going to put in systems in place to do so. We also do medication adherence, like I said, and we're currently at around 90%. So we're tracking these quality and safety metrics to make sure that our coag service moves towards, you know, whatever decisions we make, we do it systematically through our systems, and then we ensure safety for our patient for both an outcome and an adverse drug reaction. So thank you.
Thank you, Jennifer. And now to continue down the continuum of the different types of practice models and how pharmacists can participate, Marilyn Stebbins.
And I would like to say that my presentation is not a data-rich presentation because I'm going to talk a bit more about the ACO and IPA model. By way of background, I started 25 years ago as a pharmacist in the VA, and I never knew what I had until I left it. I was able to start lipid clinics, hypertension clinics, and anti-coag clinics that were pharmacist-run integrated with physician group practices in the VA 25 years ago. Moved over 17 years ago to a medical group practice that was sort of a staff model medical group, non-Kaiser, but integrated model, and really took slow steps and said, oh my God, I've died and gone to hell because I don't have any consensus and these physicians have no idea what I'm doing and they think I have 5 heads and they don't want to hear how to prescribe cost effectively. But it took a couple years, but I was able to really move the model along of embedding the pharmacist into the physician group practice and begin working under more of a global practice agreement the way that I did in the VA and expand the services and bring on new pharmacists so that we did have an anticoagulation clinic. We did have a clinic for people who couldn't afford their drugs. And then we started into a medical home model. So I want to talk a little bit about now the transition I've made now, which is back to academic pharmacy, which I've been faculty at UCSF for the last 17 years, but embedded 90 miles away from the Mecca into a physician group practice. And I moved back to academic pharmacy because I knew that this wasn't the real world. The real world was out there in the IPA and the ACO models that were just trying to figure out how they could bring the value proposition of pharmacists into that setting with this huge boon of people that needed to be taken care of. And so if I look at sort of some of the medical group models, I think that when we talk about embedding pharmacists into some of these new practice models, we have to be a bit careful because the model isn't the same as the Kaiser model. It's not the same as my Mercy Medical Group model. It's not the same as the VA model. We have a lot of disparate practitioners out there that are joining forces in these IPAs and ACOs, but they're not all in the same location. So how do we bring pharmacists into that care setting and figure out how they work? So if you've got a model where you're embedding a pharmacist, it makes sense to embed them on a team. And depending on what your need is, and I know we're dealing with cardiovascular and stroke issues today, but it makes sense to start working in a team-based model. Now, in our group, we really looked at the pharmacist as the owner of sort of the medication list and the person who was going to update that and do medication reconciliation at every point of care that they touch that patient. And I think that that's a huge piece that needs to happen in the evolving healthcare system because of the transitions of care that patients make. But if you look at it, a lot of these, again, don't seem to work in these IPA models because the group practice model, you've got a nice group of physicians that work together. You're all housed in the same area. You have your nurse case managers, your social workers, and you can make things happen in these medical home models. You can truly affect change. You've got registries, you've got EMRs, you've got all those tools. But again, we've got to figure out how to make that work in these other settings using a value proposition. We've got to figure out how do we get pharmacists doing these same roles in a cost-effective manner. How do we get comprehensive medication reviews done? How do we discontinue unnecessary medicines? How do we start omitted but necessary medicines? How do we get the ABCs going? How do we get this done? And I think that the key is when we start looking at new models of care, I think we have to look at it. Do we have that pointer? I think what we have to think about is really the pharmacist at multiple levels. In these IPA and ACO models, there's got to be good data. And the data has to get down to the practitioner. If that practitioner is a nurse practitioner, a PA, a physician, the data has to get to them. And the data needs to get to them on how many patients with hypertension are not controlled, how many people are on multiple meds and not controlled, how many diabetics are not getting down to A1C levels but on 3 oral agents, how many diabetics on insulin are not getting to these levels. If you don't have that level of data getting down to your practitioners, then you're lost. And I think the first step in an IPA model is to ensure that that data gets down to the practitioner. Even if you can't embed the pharmacist into that model because you have onesie, twosie docs and it doesn't make sense to put a pharmacist, an expensive pharmacist, into that setting, your IPA pharmacists are very capable of mining that data and working with IT folks to get that data down to the individual practitioner. Knowledge is power, and I would tell you that most practitioners out there are practicing blind. They're not sure what that patient's end goal and where they are today and how those two match when they're looking at them face to face. If you're lucky enough in an IPA to actually have a pharmacist embedded, this data is even more important because you have another pair of eyes looking to target those patients and help out your group physicians, nurse practitioners, and PAs to get people to goal. But if you don't have these group pharmacists, you have the ability of these IPA pharmacists at this next level up to get the data to your physicians, to report card them, give them the data that's necessary. The other issue we face, and I can tell you our table at lunch was incredibly lively, we had IPA physicians asking for help, developing protocols, looking for how this can happen. And you realize they're not even on the same EMR. So how are you getting data in this environment, and how are you mining disparate data and getting it down and distilling it down to the individual practitioners? This is the wave of the future. When we look at ACO models, we're not looking at models of continuous care like the VA and Kaiser. We're looking at different group practices and how do we get care affected in those patient populations. And until we start at this level that's a little bit higher up, we're not going to get there. The other thing I think, and I'm going to lead you to our next speaker, who in my mind is the true wave of the future, is the community pharmacist. How do we get the community pharmacist involved? They're out there, they're accessible, they're educated, and we've got to engage them, and we've got to get them practicing, especially in these models like IPA models, where the patient is in the community, just like the physicians are in the community, and begin the co-management of care. So I would tell you that the next little line off that needs to be here is to the community pharmacist. And I'm going to turn it over to Rebecca. So Rebecca can actually give you the pearls and what they're doing in their community pharmacies to bring care to patients, especially in these models that are not integrated and staff model like the Kaisers and the VAs.
Nice introduction. Thank you so much. Well, while we're changing the slides, we were challenged today to get outside of our comfort zone. And so I'm going to do that for just a minute. I've been a pharmacist for 35 years. So that's outside my comfort zone because I'm having to, you're doing mental math, right? So a long time. I've been in the VA, privileged to be in the VA. I was an active duty Air Force officer as a pharmacist, and I've worked in hospitals, I've worked in community settings, I've worked all over the place. But there's another reason why 35 years is significant, which I'll share in a minute. But from a personal standpoint, my husband had a stroke 5 years ago. And 5 years ago today, he was still in the hospital. He was in the hospital for 60 days. He is very disabled. It's something no family wants to go through. But I've gone from being passionate as a healthcare provider to being a zealot, I shared earlier today, and that's something I actually decided today. That's probably the best way to describe myself. This is personal, and I want to share with you just one example of what we can do in community pharmacy that typifies the future, as was aptly described. But this is just one example. Please work with me to use our imaginations to create the future. There is so much opportunity for how we can improve the lives of patients. I will share one other thing about my husband. He had hypertension, no lipid issues. He had rampant but undiagnosed polycythemia. So this is something that was completely undetected until in the ER they asked me if I'd ever been told that my husband had polycythemia. The answer was no, had no idea. Completely asymptomatic from what some of the typical symptoms might be, but it is rather a silent condition. So I want to share just something, a couple things. One in particular, a project of focus that we had this summer at Ralph's. And as I mentioned, and as you've heard, I am Vice President of Pharmacy for Ralph's. I'm also a Senior Advisor for CPHA, and I will cover some other initiatives that we've been working on. But this is one that we did at Ralph's this summer, just to give you an idea of what community pharmacists are up to. We were very active participants in the Million Hearts campaign. We worked with some pharmacy schools in Southern California. We had a number of students help our community pharmacists with this initiative. And I think everyone's pretty familiar with what the goals are of Million Hearts. So we actually screened over 1,400 customers. They weren't necessarily our patients. These were not particularly our pharmacy patients. These were not people that were getting prescriptions filled at Ralph's. These were customers in our stores that were coming in when we were providing blood pressure screenings at no charge. And we monitor, we track the demographics of these patients, or of these customers. We identified a number of comorbidities. In most cases, these were things that they identified for us, but in some cases not. In some cases, we were able to help identify some comorbidities that they might not have even been aware that they had. In addition, we were able to stratify the different types of blood pressure readings that we got, and we referred over 100 of those patients to a physician. And one of the discussions we had at lunch was how can we better refer these patients My husband and I were in an HMO at the time of his stroke. I don't believe he had ever seen his primary care physician. So there was not a relationship. When we identify these patients or these customers at a community level, we need to have means of getting them in and follow up to make sure that they see their primary care physician. Huge opportunities. In addition, we also track BMI, and we are in a very great environment. I'm a little bit biased, I'll admit that, but we're in a great environment in a grocery store to help people make better nutrition choices. We do store tours and so forth. We even have a mobile app now that focuses one on diabetes, one on heart health, and one on general nutrition to help people with issues like BMI. And a number of patients were also referred to MDs for needing help and follow-up on their obesity. So I want to shift gears very quickly. Some of you, hopefully many, most, all of you have heard that there was legislation recently passed by the California State Legislature, as well as signed by the governor just a few short weeks ago, called SB 493. This was legislation that was offered by Senator Ed Hernandez, and it basically was to designate pharmacists as providers and also to designate certain activities that a pharmacist could conduct in various practice settings. So I just wanted to review the bill with you very quickly, excuse me, and also to give you what the next steps will be, what we're working on next in this process. I was very privileged to be part of the joint task force with CPHA and CSHP to help craft this legislation. And so it went through a series of amendments, as most bills do, but this is how it is in its current form, and regulations will be crafted around what was passed. So this allows all California pharmacists to administer drugs and biologics pursuant to a prescription. So there are some programs where pharmacists can administer injections, for example, outside of immunizations. That would be one example of administering drugs beyond what is currently in practice at a community level, for example. It will also allow under protocol, which the protocols still need to be developed, and also this bill is effective January 1st of 2014, to provide prescription smoking cessation products, but just the nicotine replacement type products, not the others such as Chantix. And then oral contraceptives and travel meds. These are things that a patient can self-diagnose, or not diagnose, but self-present if they're going traveling, for example. That's not something that anyone else needs to tell them they're going to do. Access medical records. This has been a huge barrier, especially in the non-integrated models, for pharmacists to be able to access medical records, and this bill will help expedite that. And then independently initiate and administer immunizations to patients 3 years and older. Various protocols currently in existence range in different ages, but this law standardizes it for 3 years. And then order and interpret tests for monitoring, and that can be beyond lab tests. It could actually be even image, for example, if a patient has osteoporosis. Secondly, there is a designation of advanced practice pharmacists, and this allows, under certain specific requirements that a pharmacist will have to attain, and I won't get into those details now, but they will be able to perform patient assessments. It's very similar to what occurs now in a clinic-style model or in an integrated model where a lot of these things are ongoing now, but it extends the opportunity out into the community level. And then initiate, adjust, discontinue drug therapy, and participate in evaluation and management of diseases. Again, it's not to be independent of the physician by any means, but to be more integrated part of that team, even at the community level. And with that, I believe that concludes our panel. I thank you, unless there are any questions.
Just one quick question. I'm not sure this is on. But in any event, what about the ability of the pharmacist to access data in the electronic health record? That part of it. Where do we stand on that?
So the question was, how do we access what the information in the electronic health or medical record? And that is one of the biggest barriers that we have right now, for sure. There are some systems where we have an integrated model in our company. We're part of the Kroger company for tracking and documenting measurements of, for example, these either MTM or the screening results that we do. But in terms of actually being able to communicate with the EMR, the physician group, that is a very big challenge right now. What about the best that you can hope for right now is to get a PDF into the EMR. And so we're a ways away still from it being directly embedded into the EMR. But it is coming, and it's not going to be a barrier much longer, because this is a necessity in order to get this communication up and down the continuum of healthcare.
Yeah, Arnie, check.
I'll repeat it if... Ben, is the mic on?
Now it's closed.
There we go. No? Yes. Okay. So, if you don't mind, I'm going to turn the topic from clinical improvement to affordability improvement. Most professions, most health professions, mine included, are they're really positive about ways of expanding the scope of what they do. But they tend to be a little bit stingier in giving up things they're currently doing. Have you given much thought, or has anybody given much thought, as to how what pharmacists currently do could be downshifted to farm techs and people who cost a fourth of what a pharmacist costs?
Yeah, and I don't want to be the only one to respond, so maybe we can pass the microphone. But the short answer is absolutely. So, for example, there's a joint task force with transitions of care with CPHA and CSHP also, on which I'm privileged to serve. And one of the main goals of that group was to determine what things can be done by a technician that do not have to be done by a pharmacist. And there are many things. And I think the other recent change in the profession of pharmacy was a new organization offshoot for accrediting pharmacy technician training programs. And so that, there's a ramping up of technician training to be able to do more assistance.
I think also we certainly found in our medical group setting that pushing everything down to those that are, making sure everyone's practicing at the top of their license or their credentials was important. We started a pharmacy technician-run medication renewal program for our primary care doctors. So pharmacy techs were dealing with all the electronic prescriptions as well as that awful, what I call the F word, the faxed prescriptions that come into the physician group practice. And that became a function under protocol of the technicians to manage it. They were in the electronic medical record. They looked at it, the quality was far better than when the physicians did it, because when a physician gets them at the end of the day, there's 25 or 30 there, times 11, times 11, times 6, times 11. What the technicians under protocol had to do, they had to look at the last visit, they had to look at their future visits, determine if it fell within their scope under protocol, and then physicians only got those things that couldn't be solved by the technician. We then moved to our anticoagulation clinic, and our anticoag pharmacy techs do all of the stable labs. So they call back all the patients who are stable, and that takes a huge amount of work off of our pharmacists. Looking now down in the future of how you get medication reconciliation, especially in transition programs, started by technicians and then escalated to pharmacists, is another area.
And I'll just add one additional thing. We've spent a lot of time in the VA trying to get pharmacists at the top of their license by shifting things to automation, eliminating redundancies and all of those other efficiencies and moving things to tech. But we have the benefit of federal supremacy, so we don't worry about state law. And I'll tell you that's very important with moving the appropriate tasks to technicians, because the laws in not only the state of California but in across the country are very disparate in terms of what they allow technicians to do, and the training programs for technicians, the technician schools have super different levels of quality. And so there really needs to be a lot of work on standardizing the practices of pharmacy technicians and the training of technicians, and realigning the laws in many of the states that, you know, ourselves and DOD and Indian Health don't have to deal with.